OsteoSignal Episode 21. This is OsteoSignal with Neal O'Neal, a podcast exploring how your body's natural design connects with osteopathic science, translating complex signals into practical insights so you can truly thrive.
Welcome to the OsteoSignal podcast. This podcast is about understanding how the body actually heals, how structure, physiology, and signaling systems work together to determine whether a person is struggling with disease, merely surviving, or truly thriving. My name is Neal O'Neal. I'm a clinical osteopathic manual therapist and a physical therapist. My work focuses on translating complex physiology, neuroendocrine signaling, biomechanics, immune regulation, and nervous system function into hands-on clinical methods that help restore adaptive capacity in patients. Much of my perspective comes from years of clinical practice combined with training in translational research, where the goal is to bridge the gap between laboratory science and what actually helps people recover function in the clinic. Joining me today is Brent Mayberry, a fellow osteopathic manual therapist whose work focuses on integrating structural treatment with the body's autonomic, endocrine, and visceral systems. Brent brings a deep clinical perspective to these discussions and helps ground many of the concepts we talk about in real patient care. Hey, Brent.
Hey, how's it going, Neal?
Oh, not too bad. And helping guide the conversation is Brent Mayberry, our podcast facilitator. Brent is an engineer by training, which makes him the perfect person to ask the kinds of questions that many listeners are probably already thinking, helping translate some of the deeper physiological concepts into language that is clear, practical, and understandable. Together, our goal with OsteoSignal podcast is simple: to explore the signals that regulate human health, and to discuss how osteopathic manual therapy can support the body's ability to adapt, regulate, and recover. Today's episode focuses on one of the most important regulatory systems in the body, the neuroendocrine axis, and why understanding this system is critical for moving patients from failure to thrive to survival and ultimately towards thriving. So today we're going to talk about adrenal disease in pregnancy. And of course, this is continuing on with our series on the neuroendocrine axis, understanding the hypothalamus, pituitary, thyroid, adrenal, gonadal axis, and using the placenta as a means of elucidating the problems and the when the system goes bad or how the system fails to be responsive to the needs of the individual. And in the case of pregnancy, the needs of two individuals. So this is an osteopathic integration perspective. The hypothalamus, pituitary, adrenal axis, the autonomics, both the parasympathetics and the sympathetics, the thoracic inlet, the lymphatics, and onward. So we will look at the neuroendocrine axis dysfunction through the knowledge of pathologies in these same structures. So our core regulatory model, the adrenal gland, is that it's not just an endocrine organ. Most people think, it's a hormonal organ that just puts off hormones. It really and the adrenal gland is much more than that. What the adrenal gland is it is a gland that sits on top of the kidneys, and it releases adrenaline or norepinephrine. Well, epinephrine, adrenaline, and that's a very powerful chemical that helps set your body into a fight or flight on a much more wide-based basis. So what it does is it actually takes in information from all of the sympathetics, all the sympathetic information being taken in, and summates that and decides how much activation the system needs. So we talk about cortisol all the time, about how cortisol is your activation level. And then if you have chronic activation, then that's what we call chronic stress, and that you break down. So the adrenal gland is not just an endocrine organ. It's a HIPAA axis regulator. It helps determine how upregulated or downregulated the hypothalamus, pituitary, thyroid, and gonads are going to be. So the sympathetic nervous system output, it alters genetic expression epigenetically. So one of the primary things the adrenal gland does is by releasing adrenaline, or what we call epinephrine. That epinephrine is different than norepinephrine that the other sympathetic nerves release. Norepinephrine is an activator, a local activator released by sympathetic neurons to cause something to happen, right? But the adrenal gland actually upregulates or downregulates many different areas of the body, and since it's part of the neuroendocrine axis, its job is to make those changes occur over time. And so it releases a slightly different chemical than the rest of the sympathetic nervous system. That's why we call it the sympatho-adrenal system, because kind of the king of the sympathetics is the adrenal gland. When it releases hormones, epinephrine, or what we would call adrenaline, that chemical epigenetically changes the expression of genes so that the organism, the patient, changes for a long period of time, and that some interaction or some other force has to cause that change in the epigenetics to alter, to go back to, say, a normal thing. So then that's really where we see a lot of times in the literature we talk about adrenal fatigue, and the medical world, the doctors are like, they don't really like that term because it's, oh, we don't see any evidence of adrenal fatigue. And really what we mean more by that is that the body at high cortisol levels stops responding, right? Part of the whole dynamic equilibrium of the system is that the sympathetics and the parasympathetics rise and fall almost in opposition, but not entirely. And that's where we maintain health. So the adrenal fatigue would be if you have cortisol levels and adrenaline levels that have changed your how you express your genes, then the system kind of gets locked into one mode of operating, and then that degrades over time. That dynamicism is gone. You really get locked into this one mode of function. So that's really what we mean by adrenal fatigue, and really we mean the patient is fatigued, the patient is tired, and though the funny thing about it is while they're fatigued, they'll be highly activated, right? It's kind of this dichotomy there. Now, the adrenal gland also...
Is it kind of like, sorry, I just wanted to jump in. Is that like the body's like crying wolf constantly? Is that kind of an appropriate analogy? The body's crying wolf constantly, and so you just get tired and...
Right. You
just
lose
can't
responsiveness
properly.
So it is. It's exactly the boy who cried wolf, because the boy who cried wolf called wolf so many times, people stopped responding. And that's exactly it. If the adrenal levels, the cortisol levels remain high, then pretty soon the body just stops being responsive to it, because initially you get these huge changes. And while the system is shifted that way, and then even genetically those lock in, pretty soon there's no dynamic equilibrium there. There's no homeostasis, as we call it. So really, exactly as you say, the patient's body just kind of gets inured to the change in signal. There is no change in signal. And one of the ways,
and then are you also going to elaborate on the epigenetic changes that adrenaline or epinephrine causes? Is that something you're going to elaborate on today, or is that
not really
another
today?
Episode? Okay.
Let's do that in another episode. That gets really deep, and that's a very specific thing. I mean, I think that's what we see in autoimmunity, and again, adrenal fatigue, things like that. Particularly which genes get locked on. This is one of the ways that autoimmunity gets locked in or gets really set off. That you have adrenal activation that goes on for too long. It causes epigenetic changes. So those normal regulatory pathways, genetic pathways, they also get turned off, and the system just gets put into this fight or flight, high activation level at all times, which is why the fatigue comes on, because you're just burning your energy and never kicking in. So I don't want to get too specific about which genes and stuff. We should do that in another
That's
podcast.
Fine. Yeah. No worries.
So one of the big changes that the adrenal gland makes in the body is it affects circulatory dynamics. And what we mean by that is blood shunting. There are certain parts of your brain, like let's say you're being chased by a tiger. There are certain parts of your brain that you need to turn off. You don't need to be memorizing next week's spelling words if you're in school, or memorizing exactly what you're going to say in a speech later today. What you do need to be focusing on is, how can I get away from this tiger? And so certain areas of the brain will actually have blood shunted away from them. Your stomach, intestinal tract, there's no point in digesting breakfast if you're going to be the tiger's breakfast. So you're going to shunt blood away from those structures, gut structures, so that decreases gut function, right? Doesn't turn it off, but then it activates into muscles and certain parts of the brain. So again, back to that adrenal fatigue and the changes that have happened. If that occurs and it just stays that way, then then digestion starts to wear thin. It doesn't happen appropriately. And then people start saying, well, I have this problem or this problem with digestion. And then what that really may be is the adrenal gland has changed how they digest, and it hasn't been unchanged, if you will.
One thing that I know you've taught us in classes too, is, and I use this analogy with my patients all the time, is like, well, when you get a phone call with bad news on the other end, right? What's the first thing you feel? Is you feel this ugh in your stomach, right? And then instantly your brain is like, do I need to call my husband? Do I need to get my kids from school? Do I need to hop a flight? Do I need to call the police? Do I, whatever it is, right? And then when we are working on patients, we're always listening for like gut sounds, right? Because we're hoping that we're taking that stress down and that we can actually hear and feel in our treatment that the gut function is starting to return back to normal, and that not that elevated baseline, that it's actually starting to come back down toward like a 2-0. So it's actually pretty impressive. Once you guys explain that to me, that's really helped a lot with my clinical practice, is to be like, well, we're fixing this, injury that caused you stress, but then we got to go treat this other stuff because you're not digesting food now either because of the high stress you've been under, and that caused by the injury or by the, all the stuff that's happening to you. It's all there together. So.
Exactly. Well, and then the problem with that also is that over time, once you've made those epigenetic changes, and I suppose this is where we see a lot of the epigenetic changes, is that it changes immune signaling, which is where it sets off autoimmunity, in that it changes the sensitivity of your white blood cells. It changes which pathways you're using. And again, hey, we're on the lookout for really bad characters here in the body, as opposed to, the neighborhood's quiet, we don't have to worry about too much. Turn on those other more healing interleukins or signaling cytokines, is what we call those. Cytokines are cell to cell signaling chemicals. They just get altered, and then only a certain group of them are on all the time. And then, of course, we've already been describing that the adrenal gland sits right at the center of stress physiology. Now, and the problem with pregnancy and the addition of this interloper, the placenta, is that the placenta is also using the adrenal gland to up regulate and down regulate certain aspects of the body. And so now all of a sudden you've amplified these other effects, the HIPAA axis regulation, the sympathetic nervous system output, which alters genetic expression, circulatory dynamics, right? Now, obviously the placenta wants to change circulatory dynamics and shunt blood to the placenta, right? So it's going to also make it so that the mother doesn't activate in other ways. It's going to change immune signaling. The placenta's job is to, talk the mom's body into not having an immune response to the fetus and to the placenta. And so it has to do that through the adrenal gland of saying, hey, do this, but don't do that. And it certainly adds to the stress physiology, as any pregnant lady will tell you. Now, sometimes people are very, very peaceful during pregnancy. And you think, boy, that poor lady doesn't know the craziness about to come, but it's just that alteration in the adrenal gland. So the HIPAA axis during pregnancy, the normal axis, the hypothalamus, releases corticotropin releasing hormone, which is a 41 amino acid peptide hormone. Now, I only mention all those numbers because now that peptides like GLP-1, et cetera, are much more commonplace and people are speaking of them, we want to make sure that we let people know, like, look, peptides are your neurotransmitters in a lot of ways. And so a 41 amino acid peptide is a relatively small peptide, or what we might call a partial protein, because it's not really a complete protein. It's not until that comes in contact with some other protein, that it completes the protein, but changes whichever protein it comes in contact with. So it's a 41 amino acid peptide hormone and neurotransmitter that acts as the primary regulator of the hypothalamic pituitary adrenal axis, initiating the body's response to stress. So hypothalamus releases corticotropin releasing hormone. The pituitary releases adrenocorticotropic hormone, ACTH, which is a vital pituitary hormone that stimulates the adrenal glands to produce cortisol, which are crucial for managing stress, regulating metabolism, blood pressure, and inflammation. So you can see right away that the adrenal gland is very important in chronic inflammation, high blood pressure or low blood pressure. And really what we want to say about that is because people also don't always respond to exercise like they should. And people say, look, I'm exercising, but I'm just not losing weight. And it seems counterintuitive. But that can still be one aspect of the adrenal gland and how it has changed the physiology of the body. So always something for the practitioner to look at, and for patients themselves to understand that, sometimes these problems can be part of your neuroendocrine axis, and why that might be a problem. Okay, so then the adrenal cortex itself, right? The cortex, releases cortisol. And so then we talk about high cortisol, and people want to reduce cortisol, and that they should be looking out for cortisol. It's horrible. It's terrible. But the real understanding here comes from understanding that there's a large structure in your brain that tells your pituitary to tell that adrenal gland to release that cortisol. So it's a system. It's an axis. It's a groups of structures in your body that are overseeing that. And so if your hypothalamus is taking in all sorts of things, and it can be good stress as well as bad stress. I mean, kids getting married or going off to college or moving out of the house is just as stressful, even though it's happy, as negative occurrences. So we have to keep that in mind, that we're going to see these things happen. And a lot of times people come to me and they'll say, oh no, you can't be stressed because now last year I was stressed, but this year I'm fine. I don't have any stress. And the withdrawal of the stressors can be just as stressing as having the stressors there, because at some point the body compensates and gets used to dealing with those. And so it really is kind of an ironic thing that withdrawal of stressors is often when you see a big change. So let's talk about the adaptation in pregnancy. So the placenta itself produces corticotropin releasing hormone, which tells the pituitary to release adrenocorticotropin hormone. And again, that's one of the ways it keeps the body from having an immune response to itself. So it has a progressive rise in, which causes a maternal rise in maternal cortisol, right? And when we're looking at things like preeclampsia or eclampsia with the changes in blood pressure, we can see why. Because now you have two structures, not only the hypothalamus, the mom's hypothalamus, but also the placenta of the fetus is trying to control the cortisol levels in the body through secondary structures. And how responsive are those secondary structures? How well does the signal get through? Does the signal stop coming through? This also causes an increased metabolic demand, right? And obviously the placenta wants this because the placenta wants mom to gain weight and be hungry so that it has plenty of glucose for the fetus. Then it also changes our immune modulation from Th1 to Th2 dominance. Now, discussing the change in the Th1 and Th2 dominance, those are shifts here in immune modulation. That's really for another time. We've discussed this in classes before. It gets a little deep, but it's certainly something that we need to be aware of. We'll talk about that in some other pod when we talk more about epigenetic changes.
Could you just explain what Th1, Th2 is for laymen
Sure, we'll just
out there
right,
listening?
Exactly. So we'll throw this out. I'll give you kind of the definition here. So Th1 and Th2 are subsets of helper T cells. So for example, CD4, CD8 cells that coordinate different immune responses. So Th1 cells manage cell-mediated immunity against intracellular pathogens like viruses and bacteria using interferon gamma. Right. So interferon, for example, when people have hepatitis C, the treatment is to actually give them interferon to upregulate this exact pathway. Th2 cells drive humoral immunity against extracellular parasites and allergens via interleukins 4, 5, and 13. So it uses a slightly different cytokine signaling system. But the whole idea is that you want this balanced back and forth approach to that. Now, and if you have a particular infection, you really want to drive that one direction. The problem is, again, with the epigenetic changes, we might change that and then it just stays there. And the problem being that these cells, once the interferon is there, it causes an immune system. I mean, people have night sweats, they have fevers, even though they might not have a current disease. And what happens is they have chronic inflammation in specific places that then, like say you have just a normal injury, like an old hip injury or something, it will cause inflammation there, degradation of the tissue, and you might actually start getting an immune response against that hip, or let's say both hips. Like you have a little bit, who doesn't, as you get older, or maybe you played a certain sport, you have some damage to your hips, but you get caught in this Th1 T helper cell subset of immunity, and that drives immunity against those structured, it says, oh, where's their inflammation? Let's go there and beat stuff up. Well, as the inflammation goes on, it denudes the surface proteins. And so now your cells say, we don't know what that cell is right there, even though it's your normal cells. So you can see how this causes a problem. And this becomes rheumatoid arthritis, right? So that would be a big problem, as opposed to, say, somebody going into a Th2 where you have more humoral immunity against extracellular parasites and allergens, well, now all of a sudden you have hay fever, right? And then every time you come in contact with, dust, pollen, dust and pollens, then you have this real strong hay fever reaction. Well, we don't want that either. That's an overreaction one direction. So if we could counter-regulate that and say, let's go the other direction, that's where the Th1 and Th2 really come in, is which kind of immunity are you currently using and which direction are you going after, depending on what you've seen. Now, ideally, this is set off by something coming into the body and seeing it. Unfortunately, like, for example, with the hay fever, it's that your macrophages or your antigen-presenting cells, other dendritic cells, et cetera, will glom onto that and then present it and say, hey, I think these are some bad things. We should kill them. And then, of course, that causes widespread immune response, which that's hay fever. And my poor father suffered horribly. So it was always terrible because he couldn't stop sneezing and coughing and eyes watering. It was terrible. So most of us have seen that in action, and it's not pretty. But if you can do something to down-regulate that, right? And again, back to the adrenal gland and understanding, like, hey, once the adrenal gland has been upregulated and then has changed that genetic expression throughout the body, particularly through the immune system, but through manual treatment, we will go and make sure that the signaling system, the whole neuroendocrine axis, is more responsive and turns on opposite circuits to say, no, calm that, turn down the Th2 and turn back up the Th1 and more get this balance. Okay, now turn the Th1 down and turn the Th2 back up and keep going back and forth so that you don't get an over response in any one direction. Okay, so that's why that's
very
important.
Cool. All right.
Yeah.
All right. Yeah. Thanks for elaborating. Appreciate it.
Yeah. Okay, so now the interpretation through osteopathic lens is if structural or autonomic dysregulation alters hypothalamic signaling, for example, the person has a cranial base problem, they hit their head, or they have some prior birth problem, or pituitary perfusion, same thing. The sella turcica strain, the sella turcica sits at the base of the skull, behind the face. It actually is, people who've gotten hit in the nose. I had a patient, it was just so interesting that she developed a lot of these problems that we're kind of talking about out of the blue. And of course, she's asked me, like, well, why could this possibly happen? And I said, well, pituitary gland kind of sits behind your nose. In fact, that's one of the places that we palpate and use to manipulate that and make changes, because it has to squeeze fluid in and out of that area to make it function properly. And she says, oh, that's interesting, because just several months before this all went haywire, I had a nose job. And so if you've ever seen the nose job, they basically take and they break the nose at just such an angle. And so obviously it was one of those things like, oh, your ethmoid and your sphenoid had been jammed. And of course we worked on that and it made a big difference, and the patient was happy. And then of course I taught her how to do that herself. It was going to take long-term change because of the surgery. So it's things like that will throw these structures off. Sympathetic drive, T1 through 4, innervate the head, hypothalamus, or T5 through 11 are to the thorax and the adrenals. So if a patient has a diaphragm problem, if they don't breathe fully on either side, and I show people this all the time of, placing their hands in their abdomen on either side. Okay, so you would basically stick your fingers into your diaphragm and see, like, does one side go down and the other side not go down? And you'd know that you have a problem there. Or if you notice that there's a little bit of a scoliosis in your back, so the easiest way is to rotate yourself to the right, rotate yourself to the left, and you might notice, oh, look at that, I can go much further to the right than I can the left, and that tells us that there's a shift there. As osteopathic manual therapists, we not only we look for those things, and then we understand that we have to change that. We have to make it adaptable. We have to make it mobile. Otherwise, you are predisposing your adrenal glands to be irritated in a certain movement pattern when you do certain activities. And that's when people come in and say, yes, I can't stand sitting at the desk, or I can't, driving is driving me nuts, or et cetera, et cetera. So we can see when these problems occur, and that you can see which parts of the body need to be changed to be adaptable and alter this cortisol production, or the drive for the cortisol production. And then even importantly for the whole body is venous drainage through the thoracic inlet. If a patient has a thoracic inlet problems, and a lot of people know this is a thoracic outlet, but in the manual therapy word, the lymphatic drainage, anybody who's dealing with a thorax, this is the thoracic inlet, not outlet, but semantics. that has a strong drive on how well do you get venous return into your heart. It's like, so your whole body has to drain venous drainage. Your whole body has to drain lymphatic drainage to this area. And if you're not draining your head down on this side and your head down on this side, you're not getting the drive of the pituitary gland. So your responsiveness to hormones is going to be altered. And of course, being on a phone, driving, car accidents. I just had a patient. She was going on she goes on hikes, and she's one of these people that loves to hike at altitude. And, nothing less than 7,500 feet is any good for her. So she goes all over the world hiking, but she chronically runs into high altitude cerebral edema, high altitude pulmonary edema, and I've added in high altitude gut edema. We'll do a podcast on that sometime. It's very, very interesting, and everything that's going on.
That'd be great.
Yeah. But she constantly has these problems. And so she has come to me. And then as we're going through this, we're saying, well, the reason that you have cerebral edema, kind of like we talked about earlier, is the cranial base problem that she has. And then her pituitary perfusion was pretty poor. And I'm going through that. And of course, T1 through 4 is all locked up. And I said, man, it's like you were in a lot of car accidents. She goes, oh, I love to ski and I crash horribly all the time. So she goes, I'm always with my head side to side for my entire life. And she's about 35 years old. So she says, yeah, since I was a kid, she goes, when I bite it, as somebody we all know said, he goes, oh yeah, there's, you can fall while you're skiing, you can crash while you're skiing, and then you can just have a full out yard sale. And I was like, yard sale? He goes, hat goes this way, skis go that way. Everything's for sale. It's all on display.
Yep.
Yep. So, yeah. So she says, oh yeah, yard sale. Totally. So yeah, which really was like, oh, okay, well, we can see why you have so much dysfunction here. And that's just it. Is she goes, yeah, but a lot of those were like, 30 years ago. And it's like, well, yeah, time is a magnifier.
Doesn't matter.
Right. It's a magnifier of dysfunction, not a limiter of dysfunction. So in working on all these things, that's how we alter endocrine output as osteopathic manual therapists. And first off, you have to develop a fine sense of analysis, of seeing that. You have to develop your visual ability to see that. We know the tests, learn the testing for that, the palpatory skills to feel changes in tissue, changes in like bogginess, or whether the stiffness of structures, and knowing that this structure has to work in a certain way. So also the experience of having treated lots and lots of patients, which is a big part of what we do. Okay, so the autonomic influence on the adrenals. Let's talk about that a little bit more, because we're kind of talking about that. Sympathetic supply. So the preganglionic fibers of T5 through T11 go to the adrenal gland. Hold on,
Neal,
Brent,
could I ask?
Yeah.
I was just going to ask you, what is preganglionic?
Yes. So preganglionic means that
because a ganglion is just like a collection of nerves in one spot. Is that
correct?
Right? So what a ganglion
correct.
is,
So yeah. So the structure of the sympathetic nervous system, the sympathetic outflow starts in your hypothalamus, comes down your spinal cord. So what we call the motor outflow, the motor signals are coming out. The sensory signals are coming in, but those come in at all levels of the body. But the outflow itself, particularly, comes out at T1 through L2. So from just above your clavicle to just below your navel. And on each side of the spinal cord, just in front of the vertebra, right about where the rib heads in the thorax come out, there are these little ganglia, these little collections of neurons. And so the nerve comes out from the spinal cord, goes to these ganglia, and then these ganglia connect to each other up and down. And then where they meet at organs and other structures, they cross. Left and right will meet. But if its structure is only on the left side, then you only get left-sided. And if the structure is only on the right side, you only get right-sided. So you get this information, for example, left adrenal gland, right adrenal gland, though they do get cross-talk because these sympathetic chain ganglia is what we call those. So these ganglia are little dots on either side of the spine going up and down. And they attach to each other going up and down. And they also attach to other ganglia, another set of ganglia in the front of you called the prevertebral, obviously in front of your vertebra. And those tend to be on the arteries. So there's lots of overlap and back and forth. So the information is shared diversely, right? It's a very divergent signaling system, so that if there's a warning in one area, it just shoots all over the body and says, let's have this big effect everywhere, which is great if the tiger just jumped out from behind a bush and catch you somewhat unaware, but you might have a chance to, if you get the signal out right away, you can respond and maybe get away. So it's a very useful, life-saving approach. So those preganglionic fibers, typically T5 through 11, but as we said, the body is not always wired exactly as you think. So T12, L1, L2 could be included in that, anywhere from T5 to L2, particularly right at that T10, 11, 12 area. So there is direct innervation from the spinal cord to the adrenal medulla, but these chain ganglia also connect to it through the various ganglia. For example, each left and right have their own aortico-renal, since the adrenal is on top of the renal. Renal means kidney, or renal. So aortical renal ganglia on either side. So these chain ganglia will come out from the spine, attach to this, and then go back around to the adrenal gland. So it's very divergently innervated. And this is what controls catecholamine release, right? So the catecholamines are just one of the sets of, it's what we use to say dopamine, epinephrine, and norepinephrine, right? So hormones and neurotransmitters produced by the adrenal gland and nerve tissue. And like I said, the adrenal gland is where you get epinephrine. The other sympathetic neurons, you only get norepinephrine. However, the adrenal gland can also release norepinephrine as well. So if it's activated enough, it does the epinephrine or adrenaline. If it's sub-activated, so it's slightly activated, hey, we need your help with this. We need you to tell everybody that maybe changing the blood flow over from digestion, we're going to go do a workout. So maybe get ready for working out. Then the adrenal gland will just release norepinephrine. So it's not always hey, we got to change the genetics. A lot of times it's hey, same life, we're doing good. We're going to go work out. Nothing too bad. We just want to be ready for this workout, or we're going to go for a run or whatever. So let's prepare for that. So it is these sympathetic neurons and their input, the sensory inputs coming in, that information builds, it's shared. And if there's enough activation, then that adrenal gland will go up to norepinephrine. Maybe it's just dopamine, norepinephrine, or if it's terrible, horrible, and something that happens repeatedly, the adrenal gland will start saying, okay, that's it. We're going to do this. We're going to change the genetic complement here, or the way that genes are expressed in the body, because we obviously live in a bad neighborhood. We always need to be on our toes. There's all these gangsters hanging out or something. All these bad tigers keep thinking they can hang out along this road and jump out from behind bushes. So something like that. Now, the flip side of sympathetic supply is the parasympathetic influence. So the cranial parasympathetics, cranial nerves 3, 7, 9, and 10, their job is to provide, and S2, 3, and 4, provide information that's counter to the sympathetic and say, hey, maybe we don't need to be activated. Maybe we need to do something else. Or back to that humoral immunity that we were talking about with Th2, that maybe they're saying, hey, we have something that maybe you ought to pay attention to, that in the lymphatic system, we found some stuff like cancer that we don't think is us, and maybe you should take a look at it. And that would activate the adrenal gland to switch over to a Th2 signaling, and then say, oh yeah, let's activate that and shift blood flow, et cetera, et cetera. Now, and vagal tone particularly, it indirectly modulates systemic stress states, right? So those are dampeners on the adrenal response. So if there's enough parasympathetic activity, that adrenal gland won't go from norepinephrine to epinephrine. It'll stay below and just say, no, we don't need to change who we are. We're doing everything. We know what's going on here. We don't need to change how we live. We're pretty aware of our surroundings and can take care of ourselves. But if that dampening influence is turned off, then the adrenals have a much easier time of being activated and going into high activation of adrenaline. So, and then those, the pelvic parasympathetics, as I mentioned, S2, 3, and 4, especially during pregnancy or any hindgut problem, genitourinary or reproductive tract problem. And that's why, like say, an ectopic pregnancy really activates the adrenals. People often know there's something really, really wrong when something like that occurs. Same with a urinary tract infection. You cannot truly sleep with a urinary tract infection. It's not something you can just say, oh, I'll worry about that in the morning. It starts irritating you at a high level. So that's where those S2, 3, and 4 are also important in dampening down sympathoadrenal response. And so if something's irritating there, the parasympathetics there are turned down, and the sympathetic activation of the area turns up, the T12, L1, L2. That information goes straight to the adrenal gland, and the adrenal gland upregulates everything, and you're up and saying, where is that doctor? I got to find an antibiotic. This is not going to work. Or you're going, I don't know what's going wrong. Oh, wait, I'm pregnant. So that's also, whoops, why can't I sleep? Oh, well, welcome to pregnancy. People oftentimes that's how people find out they're pregnant. They're like, there's something really wrong, doc. It might be a UTI, it might be this, might be that. Got a lot of back pain. I had a patient come in, she was having all sorts of back pain. And it's like, any chance you could be pregnant? Like, well, no, we're starting to try, and I was just clearing out, but I got off the pill and this, at the other, or whatever. And I was like, I think maybe you're there sooner than you thought. Maybe you want to go talk to the doctor, because her abdomen was quite rigid.
There were twice in class that I was outed by a mentor of mine that I didn't have a chance to even tell my mom. And they were doing a couple of things like, oh, can I tell everybody? I'm like, if you have to, I guess so. So, yep.
Tell everybody not to touch
you. Yeah, don't touch your. So.
Yes.
And that wasn't very far along. You're like, wow, that's amazing. They can pick up on that quickly, but it's pretty amazing.
Yes. Yeah. You'll know. So clinically, what do we see? So a hyperadrenergic state, or a hyper adrenal activation state. Somebody can have what's called a pheochromocytoma. This is always on all the state boards about what causes hyperadrenal activation. And that would be a tumor. So you can have a tumor that would cause that. But the most common one is stress overload. Too much stress, too much to handle for too long, or too many things. And this is why we talk about, having community, or having a network of people that help support you and talk to you, and so that you can deal with that stress and release it. Okay. But some of these hyperadrenergic states, they often correlate with thoracic restriction, like, for example, acquired scoliosis, rib and sternocleidomastoidal dysfunction. So if people's chest doesn't work right, so for example, here's a great example. During COVID, people were getting COVID, an infection in their heart and lungs, and the arteries, particularly in the veins in between them. So the pulmonary arteries and veins. And the pulmonary arteries and veins in the heart are actually hanging from the chest plate. And so one of the things that happens is the chest plate actually has to have this drawbridge motion that increases your front to back volume of air. And if that area gets locked up, you're going to have a really hard time turning over air in your lungs and getting oxygenation, which is one of the reasons so many people, when they had a particularly bad COVID infection, would get so much fluid in those structures that it would really dampen down their ability to breathe, and we had to put them on a ventilator. But obviously, the better fix for that than a ventilator, of forcing their chest apart, would be to make it so that the chest works on its own and limit that. So you can see where, and so of course, a lack of oxygen is going to really increase sympathetic drive. A lack of diaphragmatic excursion, like if the diaphragm can't move because the chest is just not going very far, that's going to activate those adrenals. The adrenals sit literally just under the diaphragm. And so when that diaphragm is rhythmically moving on them and squeezing fluid out of them, nice and easy, and they're working together evenly, then the adrenal gland is not going to be activated. But mechanically, it will get activated by, say, an off pattern or desynchronized diaphragm, such as happens when people fall on their back, they knock the wind out of them, and you can't get your breath going, and eventually one side comes on. Yeah, not comfortable. But that's just it. So almost everyone's experienced that. Yeah. And so that's one way to get a desynchronized or syncopated diaphragm working, and that irritates your adrenal gland. So that will upregulate give you a hyperadrenergic state. Okay. Now, pregnancy increases this by increasing the intra-abdominal pressure, right? All of a sudden there's too much in your abdomen, so you can't breathe as well. Diaphragmatic elevation changes because of loss of function, as we just talked about in the chest, and during COVID, fluid in the chest. Thoracic inlet compression risk. If you can't get your venous return and your lymphatic return back into your heart, that's gonna cause problems. And so you'll have a buildup of fluid through the whole body. And as we, for example, a lot of people say, well, they call them like cankles or elephant ankles. They'll say, oh my gosh, that's horrible. That really resists the flow of blood and lymphatics through the whole body. So it causes a lot of problems, which upregulates the adrenals. Okay, so really the thoracic inlet governs venous return from the head and neck for hormones to get into the systemic circulation. It increases lymphatic drainage of the entire body. 3/4 of the body jumps to the left, so that one's even more important. Neurovascular supply to endocrine structures. So for example, the thymus, you have all the nerves coming up through here. T1 through 4 have to come up through, go up to the superior cervical ganglia to innervate the head and neck, to innervate the hypothalamus, to innervate the blood flow to the head. So you're going to see if that signaling is off because of problems there, then we're going to have big problems. So if it's restricted, we get increased cranial venous pressure. So venous pressure in the skull. You're not washing fluid over your neurons as well as you should. Impaired hypothalamic pituitary signaling, right? Poor timing, poor responsiveness, because hormones work in this what we call a pulsatile manner. That you'll get a pulse and then a down and then a pulse and a down. And so it's more like a wave rising and cresting and troughing and cresting and troughing. If you don't get that, if you just get this, there's no dynamic change in the structure. So glands and receptors are not going to respond as well. Okay, so one of the big things we're going to see, for example, in pregnancy is plasma volume expands, right? So that you just have a whole lot, the mother has a lot more volume of plasma. And so she's going to have a harder time. Now the thoracic inlet becomes even more important. And unfortunately, what's happening is her posture is changing dramatically, right? So as the weight increases in the front, the plasma volume increases. It really puts a ton of pressure on that venous return system, right? So the venous congestion increases, lymphatic load rises significantly, and any structural restrictions become amplified by the hormonal dysregulation, right? So not only are the postural changes in mom because of redistribution of weight, the increases in volume redistribute how she works, but then also, so any body problem or postural adaptation that she has is going to greatly increase during that time. The hormones, like for example, relaxin, et cetera, are going to amplify that effect and allow her to go even farther than she would. So the resistance to changing posture is dampened down as well. So we can see this is going to be a huge problem. Okay, so, and then the adrenal glands are highly vascular. So lymphatic congestion may increase inflammatory signaling, alter immune-mediated adrenal function, and exacerbate autoimmune patterns, as we already talked about. Okay. So let's talk about some of the specifics, because here's where the disease process and understanding like normal, like what, MDs would say, okay, here's a disease process, here's a pathology. We need to understand then, and understanding that a lot of what we're looking at is not maybe, obviously you want to refer out if the patient has any of these symptoms badly enough, but also that even once the patient has a diagnosis and the doctor's like, yeah, I'm watching them, they're okay, go back to your normal lives, but the patient's still not comfortable, they're not functioning well. Our job is to take away that penumbra, that area around it, and ideally just limit the pathology to a lessened area to make the mom more comfortable or the person more comfortable, because as men, women, we see this in the clinic all the time. So for chronic sympathetic tone, primary aldosteronism, right? Aldosteronism or hyperthyroid or hyperadrenalism. Chronic sympathetic tone, that person is always on edge, right? So we really have to make sure that their thoracic spine works, that their ribs are functioning properly, they have appropriate diaphragmatic tension, that they are synchronized in their diaphragmatic excursion. Now we also have to watch out for excess sodium retention, right? They get a big fluid shift. If they're holding on to their sodium, now what are we going to do about sodium? There's a capsule around the kidneys, and if the kidney has hyperadrenal innervation to it or upregulation from the adrenals, then they're going to hold on to more sodium. Our job is to ease the tension on that T10, 11, 12, which is kidney and adrenal, and the capsule around the kidney, to make them to lessen this tone or the effect of this tone. Now, the opposite side of that is, or not the opposite, but another version of that is chronic hypothalamus pituitary adrenal overactivation. So again, like what we call Cushing syndrome. Right. So Cushing syndrome, the official that obviously it's a prolonged exposure to high levels of cortisol resulting in weight gain. And that's the moon face that we see. So sometimes you'll see a patient who just has gained a lot of weight so that their face almost looks round. They have that apple body look where they have a large abdomen and then thin legs. So that's chronic hypothalamus pituitary adrenal overactivation. So they have high cortisol levels. So again, back to the cranial base compression, make sure this phenobasilar works properly, upper thoracic. So for patients at home, even foam rolling their upper back, making sure that they have their entire rib cage, making sure the entire rib cage works. So foam rolling the side, but also going to your osteopathic manual therapist who will make sure that you have proper rib function, proper cervical, thoracic, and cranial function. Now, this is why people have that apple look to their body, because the excess cortisol impacts glucose regulation, blood pressure, and immune modulation. And when we say those terms, we're really talking about brown fat, that abdominal fat. So most people don't understand that there are three kinds of fat: yellow fat, white fat, and brown fat. And that brown fat is actually an immune sensitive organ, an immune regulator in the body. And so it responds greatly to cortisol. It grows in response to cortisol. So these hyperactivated people will just have their body type, their body's composition will change greatly. And those are the people that do the yo-yo dieting, and they just can't get anywhere. And they say, I don't understand why I can't lose weight. I can't get rid of this abdominal fat. And we all know that abdominal fat is very bad for you. And that's why, because this is a hormonally active fat, but it's mostly sensitive to cortisol, and then actually changes your hormonal balances in your other systems as well, your estrogen, your estradiol, your adrenaline, et cetera, et cetera. Okay, so that's why that's so important. Now, the flip side of all these is adrenal insufficiency, right? So we had too much adrenaline, we had too much cortisol, and now we want to look at too much or adrenal insufficiency, like not enough adrenal outlay, right? You need to be responsive to the needs of the body. And if you're not responsive, these people are often fragile. They have a fragile autonomic tone. They have a real risk of hypotension. So we do have those patients who they go to stand up and they somewhat faint or go, whoa, I get really lightheaded. Those people also have a problem. And it might be the same exact problem that we're looking at with hyperaldosteronism or hyperadrenal interaction. It's the very same areas: the thoracolumbar junction, renal fascia. Look at the mesenteric tension patterns, right? So we have to make sure that these people also do lymphatic and circulatory support. So there's a huge interaction here with the adrenal. The adrenal goes many different ways. So pregnancy really shifts the center of gravity. Let's move into pregnancy-specific biomechanics. The pregnancy shifts the center of gravity anterior, lumbar lordosis increases, rib cage flares, right? Diaphragm elevates. So again, we have far more problems during pregnancy with this shift in the system. And all those things put greater pressure on the adrenals. They cause them to hyperactivate. And we really don't want that. As we've seen, we've already talked about what happens and what we would do about that. Now, the flip side of that, or the follow-up to that, is the postpartum rebound. So after delivery, we see a rapid endocrine withdrawal, right? All of a sudden, the placenta has gone away. It's not pouring cortisol or corticotropin-releasing hormone into the system. And so the pituitary stops being activated. So all of a sudden, headaches, severe mood swings, because the brain structures are going to be changed. They're not receiving the same chemicals they were when that placenta goes on. So it's kind of like a bad relationship, right? It's terrible when it ends. The brain gets addicted to those chemicals being fed to it, and then when they're withdrawn, all of a sudden the brain goes through somewhat of a withdrawal effect. So we have to kind of understand that. So we get immune reactivation. So all of a sudden, mom has reactions to everything. She gets inflammation everywhere. There's an autonomic recalibration, and this is where osteopathic manual therapy really comes in. Can we help make allow the hypothalamus to function better, the pituitary to be more responsive, reduce the stress on the adrenal glands, that now that all of a sudden that posture that had gone all one way now pops back the other way, when any of these previous postural adaptive patterns are now really locking in as the relaxin from the placenta reduces, that those problems are going to get locked in. So the best time to work on the mom is right after she gives birth, so you can restore function most easily. And this is why, because of this postpartum rebound, the adrenal gland really facilitates the autoimmune flares, right? A lot of people find out they have autoimmunity at that point. Thyroiditis, right? Hashimoto's thyroiditis. The thyroid really goes crazy. So the real key to treating the whole neuroendocrine axis, particularly after pregnancy, is the adrenal gland. You really have to make sure that the adrenaline is not being produced, that there is enough suppression through proper pelvic function, proper cranial function to the vagus nerve, and the S2, 3, and 4 have to inhibit the adrenal gland from functioning, from over functioning. Okay, so back to, and we've said this time and time again, we as osteopathic manual therapists, we look at the structure and how that affects the autonomics, how the autonomics change the circulation, and how circulation regulates the endocrine function. Because if you don't have proper circulation, if you don't have proper drainage, the hormones cannot flow and cannot be responsive to each other, and the glands on this neurohormonal axis cannot interact with each other and communicate. So the osteopathic role is not to replace endocrine care, but to optimize the terrain in which the endocrine regulation occurs. Okay, so, and that's really where this comes down to, is making sure that we have a responsive system. Not that we're not going to fix anything, but we're really going to make that system far more responsive. And you can really see that the placenta, when it deforms this neuroendocrine axis, how it really affects these adrenal glands. And then you can, and so in every mother, we can really see, oh my gosh, look at how this has really changed. And we can see what the changes are in her body, and then how she recovers from pregnancy when that placenta goes away. So you see how they respond when the placenta comes in, and then you see how they respond and how much control they have when the placenta goes away. And that what that does is it reveals to you where the mother has underlying inadequacies or iniquities in her neurohormonal axis. And we can use that information when we see that in certain patients and say, oh, well, that's interesting, because I also have these male patients who don't get pregnant, obviously, that I see some of those disturbances in them. You start to recognize those symptoms. You start to recognize those, how these things appear, and go, gosh, this guy kind of has a big beer belly and he acts a certain way. I wonder if he has adrenal problems. I should really look at it from that direction and say, does his cranium work with his viscera, with his diaphragm? You really have to integrate all of those aspects of it so that you get neuroendocrine function, you get autonomic function, the immune system is properly mediated, and that you get appropriate circulatory changes. Those people who say, for example, women say this all the time: my hands are always cold, my feet are always cold, and that's lack of circulatory control, lack of shunting. And so you always want to look at that in a lady that says, oh gosh, my feet are always cold. First, you look at the adrenal gland and how is it responsive to the rest of the structures. Can you make the hypothalamus and the adrenals work together? Can you make the cranial base, C1, 2, and 3, work together with the diaphragm and the adrenals? Does the pelvis work properly with the adrenals? Is there responsiveness there? So, and for patients, this is something that, you can always read more about this, but that understanding that there's somebody who can make differences that aren't medical level. We don't have to give you chemicals. We don't have to give you pharmaceuticals to make these changes. And that, there's a lot of other fixes out there. People are saying, oh, tap your arm twice, and that tells your vagus nerve to turn up, and tap your right arm, tap your right arm, it tells the vagus to turn up, and tap your left arm, it tells it to turn down. The system's far more complex than that. And if
Yes.
when somebody's having a problem with something, if they're not looking at the adrenals, they're missing a massive part of the entire system that we really have to.
I remember years ago, Neal, you helped me with a patient that I was having trouble with. And I remember her symptoms were extreme pain. I remember her clothes hurt her. Do you remember this lady that I'm talking about?
Yeah.
And that was where I was like, that's adrenals. And then when you treated it, I was like, wow, I've been kind of stuck with this. But that extreme pain and that just that hypersensitivity of stuff, it's sensitivity on one side and then desensitized on other things. But yeah, and she had tons of medical intervention, but seeing you do that with her adrenal, I was like, wow, I had no idea that was adrenal problems that do that stuff. So that was fascinating.
Yeah, it's pretty neat when you see it. It's like, oh, wow, who knew? Okay, well, as we wrap up today's discussion, it's worth remembering that the body is not simply a collection of parts. It is a dynamic signaling system. Health emerges when the body's major regulatory networks, biomechanical, bioelectrical, and biochemical, communicate effectively. When those signals become distorted or restricted, physiology begins to drift from thriving to surviving and eventually towards failure to thrive. And as osteopathic manual therapists, we strive to understand those systems and turn that about and return our patients to thriving. So the purpose of osteopathic manual therapy is not to replace medicine or eliminate disease on its own. Instead, its role is to restore adaptability, to improve motion, circulation, neural regulation, and the body's ability to respond appropriately to internal and external stress. When those fundamental signals are restored, the body often regains its capacity to regulate itself. That's the central idea behind OsteoSignal, understanding the signals that govern physiology and using that knowledge to help patients move towards greater health. Thank you for listening to the OsteoSignal podcast. I'm Neal O'Neal, here with Brent Mayberry and Brent Mayberry. And until next time, keep paying attention to those signals.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neal. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Want to show your support for the podcast? Give us a like, click subscribe, and leave a comment or review. We appreciate it. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neal.